Assalamu alaikum and welcome to the Mamluks podcast. My name is Sim. We have an important and prudent episode for you today. We have Dr. Akbar Ali and Dr. Omer Hussain from their respective hospitals here, helping you understand a little bit more about the coronavirus COVID-19 outbreak that has transpired over the past few weeks. Welcome, both of you. Dr. Akbar Ali leads the clinical operations unit of COVID-19, not leads, but is part of the COVID-19 unit at his hospital. And Dr. Omer Hussain is also a critical care lung specialist, right?
Right.
And thank you both for joining us this afternoon. It's a tough situation. Dr. Akbar Ali is a cousin of mine, someone who is a huge inspiration throughout my life, and I wanted him on the show for many months, and it sucks that we have to come to this type of a situation for him to come on. It just we're living in a crazy time, and a lot of Muslims around the community, a lot of people in general, are just incredibly scared and confused about what is happening around them. Alhamdulillah, I think they're complying with a lot of the recommendations regarding safe distancing, self-quarantine, all those measures that have been in place by their local authorities, right? So where do we go from here, Dr. Akbar? How do we handle I guess first of all, let's just start from the beginning. How do we identify some of the symptoms related to COVID-19? Who is affected by this? How do we know whether we should go to the hospital?
Sure. Assalamu alaikum wa rahmatullah. Bismillah wa salatu wa salamu ala Rasulullah. Jazakallah khair for hosting us. We agreed to do this podcast to deter people, especially Muslims living in America, from consuming and propagating misinformation or disinformation, aka fake news, and to dispel rumors and myths regarding the coronavirus and address what people need to do now. More importantly, we're not here to play the blame game. This is meant to be an informative and educational service for all of us. And we are here to unite folks that are in the public sphere, the professional sphere, and the religious sphere. So finger pointing at this juncture is counterproductive and in no way beneficial to any of us. Okay, so jumping in to what the COVID-19 presents as, and I'll go ahead, defer to you.
Well, my name is Omer Hussain again. Sim, thanks for inviting me over.
Yeah.
My pleasure to be here. And like Dr. Ali said, it's what we want to accomplish here is some education, and the education we'll provide will be correct. But right off the bat, I got to tell you right now, it's Sunday evening around 6 o'clock. Things are going to change. What me and Dr. Ali say today may very well be incorrect tomorrow.
Yeah, that was one of my biggest concerns about having this show, was that how quickly the nature of the situation is just evolving, because it's so new. There's very little precedence for a global pandemic in a modern era. The last time we had something similar to this was the Spanish influenza in 1918.
Right.
How do we, we're charting history now, and we're trying to figure out what's working best. People are giving suggestions from Italy, from Spain, from various East Asian countries. How are you guys processing this, just being medical professionals?
Right. Well, it's hard. And like your great leadoff question is, well, how does it look when we first see it? And the problem is, like, there are some traits. It kind of does look and feel like the flu. Akbar, interrupt me whenever you think I'm wrong, but it's cough, shortness of breath, low grade temperature, just not feeling well, but still not your typical cold. Sometimes a little bit more than that are the symptoms will get you to seek medical attention. That means you're sick, but you can also be infected and be able to transmit to others without feeling that bad. And that's the tricky part. And that's why this disease is a different animal compared to its cousins that we've seen before.
Yeah.
The others, the MERS, hit you hard.
Yeah. So explain a little bit about what MERS and SARS, how they were also coronaviruses, but this virus is a little bit different from those.
Right. Well, First off, I mean, the coronavirus, me and Akbar studied it as the virus that caused the common cold when we were in medical school, like 20 some odd years ago. That was the name of the coronavirus. Since then, it's mutated. And like you point out, the MERS and SARS are recent additions of it. The SARS being back in 2003 or so. And the way it happened was you got sick kind of quick. Mm-hmm. And that way it was kind of obvious that you shouldn't be around other people. MERS, similar, and those cause death, a lot more often than this current COVID-19 does. Same story with MERS. It was also a similar virus, but again, the way it got you was it got you sick fast. You didn't have time to give it to other people, and you can isolate pretty quick. The evil thing, and I have no problem calling this virus evil, is that it lays low after you get infected for maybe 4 to 14 days without giving you much to go off of to tell you that you are sick.
So while you're in those 4 to 14 days, can you pass it on to other people?
Yes.
Without even coughing, without exhibiting symptoms?
It could be very minimal to trace. Yeah, the cough is probably the easiest way to transmit it.
Yes.
And the fastest way, but...
What about a kiss to a child or
Yes.
to a spouse?
Yes.
Saliva can...
Any kind of droplet from the oropharyngeal cavity, nasal cavity, touch is something which can transmit this virus, this droplet.
Okay. So it doesn't necessarily have to be coughing.
No, so any type of secretions. So the CDC doesn't feel that it's airborne currently.
Yes.
There's no data to suggest that it's airborne. We all feel that this is respiratory droplets, so secretions from saliva, sputum, secretions from sneezing, and even sweat.
Okay.
So holding hands or even kissing definitely can do
Holding hands as well.
I think if you are taking care of somebody and you come across their secretions, I think it's definitely possible.
Yeah, and Dr. Ali pointed out, it's like a lot of it is hands. It's me touching someone else's hand or me touching where they sneezed or where they put their hand. And then I go ahead and unconsciously touch my mouth, my eyes, my nose. And all of a sudden I'm infected with what was on the table, for the past 24 or maybe longer hours.
Exactly. So it's actual physical touch. So with some sort of respiratory, secretion.
Okay.
So that could be on your hand, that could be on your face, and if you come across that and you touch your face, then yes, it definitely can be transmissible that way.
All right. So that's I guess why there is the alarm. There is, right, in the medical community. I think the scientific community has really. I don't know if it's too much of an alarm that they raise, but maybe you guys can help sort that out. Is the alarm or the awareness regarding this exaggerated or no?
I don't think it's exaggerated at all. I think it's a very appropriate level of alarm that's been raised by Governor Pritzker here in Illinois, by Governor Cuomo in New York. You see him all day. And they understand that the only way to control this is to separate and to stay in place in your home, because otherwise it's really easy to spread. And while we're really highlighting how easy it is to spread, it's really easy to prevent. Stay in your home, don't go out unless necessary, and it's super easy to kill this virus. It takes soap and water for 20 seconds. That's really what it takes. It's not some kind of hardcore fungus that's going to be really hard to bleach away. You need just soap and water for 20 seconds. You've done the job.
All right. Well, so we have the preventive measures in terms of, making sure that we maintain safe distancing, where, cleaning up after ourselves, washing our hands. What are some things that we could do in terms of diet, nutrition, vitamin supplements? How can we boost our immune systems during this time so that we're protected?
That's a little hard to answer for this virus. I mean, I think overall, nothing yet proven. I mean, people are hoping that things like vitamin C and things like that you see out there can be helpful. Zinc. I mean, it's not. I mean, taken in appropriate quantity is not going to be harmful.
Yeah.
But in terms of being preventive, would be a bit of a stretch at this moment. I think the only thing that we've seen that prevent it are, what the governor's saying: stay at home, stay apart, and wash your hands are still the only things that we can reliably say prevent this disease.
Right. I mean, as Americans, we look to the CDC and governmental agencies, right, for updates and guidelines, best practices, and overall education. But I think the other thing you can do as Muslims, we have another powerful medicine in what the Prophet ﷺ, prescribes, in the Sunnah to avert calamities. So as far as medicine that's out there, the CDC hasn't endorsed anything specific. They've kind of given almost full autonomy to institutions and health systems to come up with their own protocols, their own guidelines, and their own best practices. Okay,
Yeah.
They've given full-blown autonomy to them. But as kind of overarching, they have mentioned some guidelines, and they haven't made anything specific yet. The best control that human beings right now have is staying away from other people that are known to have this, and to enforce social distancing, self-isolation. Only one member of the family goes out if if it's a dire emergency and they need to pick up some groceries or medicine. And then, frequently washing hands and practicing proper hygiene.
Yeah. There's always a smart aleck in the comments who will say, oh, well, you guys aren't practicing social distancing yourselves. You're all in the studio. Well, the idea is that we were planning on doing a video conference, but because of the high bandwidth usage in this area, where the internet's fluctuating and flapping all over the place, so we decided to have it in studio, but with all the measures and safeguards in place, where we didn't even shake each other's hands when they came to our studio. We didn't greet each other in the typical Muslim fashion or even traditional cultural norms that are associated with greetings. But and we were also wearing gloves and things like that. So alhamdulillah, we're practicing what we preach here. We don't want anyone to get the idea that this is just stuff for the average person to practice. This is commonplace for everyone, right?
Right. I mean, one of the things I notice is that when either Omar or myself are in the hospital system, we're highly vigilant. We don't shake anybody's hands, family members of patients or even other docs. We have this elbow bump thing that we're doing these days, but we're always gloved. We have appropriate masks on if we need them.
You guys should teach him the Turkish thing.
Yeah.
Eyvallah.
Eyvallah, right. Eyvallah, kardeş.
That will spread.
Yeah. But so that's what we're doing. We're hyper vigilant, right?
Yeah.
But as soon as we, even healthcare practitioners, nurses and doctors, once we leave the hospital, we're kind of in the same boat as everybody else, because then we'll start touching our face while driving, or touching the grocery shopping cart when we're at the store. So then we have to be highly mindful of what we're doing, and the only way to do that is to minimize those type of interactions. So
Well, how would you guys describe the current response? Is it adequate? Do we need to do more? Specifically, the Muslim response to this, maybe. What's your assessment of what's going on so far?
Well, I think it's too late. In my opinion, I think we're doing the right things right now, but everything we're doing right now is unfortunately, based on the numbers we're seeing from New York,
Yes.
based on the numbers we're seeing from Washington State, from LA, is too late. Last time I checked, in Chicago or in Illinois, we've had 753 cases. That's of this morning.
Yeah.
And
many of these people don't even, a lot of people who are already infected haven't even been getting tested. So these are just numbers that the hospitals are reporting, that the hospitals that have these testing kits available. Is it, and regarding the testing kits, are all these hospitals even equipped with these kits is a question as well.
Some are, some aren't. I mean, some are. We all have the Illinois Department of Public Health available to us to send kits to, but there are, as Akbar said, a lot more not homegrown, but hospital-based kits and hospital-based testing measures, which are coming online. and are getting fast-tracked to being used at the bedside. So it's going to be varying from wherever you go, hospital to hospital, system to system. The turnaround time is going to be 6 hours, 8 hours, 24 hours, to as long as days.
And I mean, just how would this was mainly kind of brought to the national limelight 2 weeks ago, for all intents and purposes.
Mm-hmm.
How did they ramp up production on testing kits so fast? And because I'm sure there's some kind of a protocol in approval and all kinds of different red tape that you have to go through in mass manufacturing testing kits at this capacity.
Yes.
How are all these hospitals around the nation getting testing kits at this type of rate? Unless they already knew about it.
I don't think most of them are. From my contacts in California and in Boston, a lot of hospital systems, unfortunately, don't have enough masks.
Yeah.
Don't have enough personal protective equipment. And some of them don't have enough swabs. So these are the testing kits we're talking about are swabs.
Right.
Okay. So they don't have them. And they are getting I think the federal government with the CDC and the WHO, they're trying to get a lot of these hospital institutions swabs and testing kits.
Okay.
I think there is definitely a little bit of lag in the supply chain, but certain health university health systems, they're doing a pretty good job of ramping up production and ramping up testing on a daily basis. And I just wanted to share some of this is anecdotal data. Okay, this is not confirmed by the CDC, but in Illinois. Currently, it seems that people that are being tested, 16% are testing positive. 16%. Okay, and there have been upwards of 10 to 15% false negative testing that's going on, and that's because either the patient that was swabbed, it was too early in the disease and they didn't have enough of burden of this RNA, or the specimen wasn't collected properly, meaning whoever inserted the swab didn't go deep enough into the nose. Okay, into the nasopharynx. So, and the other thing that is kind of interesting is comparing the world coronavirus cases with the U.S. Okay, now so the U.S. Today has more than 32,000 cases documented. Okay, this is per the Worldometer, and then more than 400 deaths. Now, if you compare that to South Korea had less than 9,000 cases. They started testing a lot earlier, and they only have about 100 deaths. Okay, so exactly, there's a 4 times difference between South Korea and the United States. And South Korea is on their 3rd or 4th generation of this PCR testing. Okay, so they're well advanced, and they've been testing. So what the scary part is.
Wait, what does 3rd or 4th generation mean?
Meaning that they've actually increased the sensitivity of their testing.
Okay.
By improving on their technology of testing.
And the scary part thing is?
The scary part is that South Korea has almost tested everybody that has even you sneeze, you cough, you get tested. Okay. And then you get isolated or quarantined, or you're told that, you stay home for about 7 to 14 days. Okay. So they've tested a lot of people. The United States has not tested that many, and we already have so many cases. And we have 4 times the individuals that have already died from this disease. Now, and we have not been testing that many people.
When you say test, you're talking about taking a sample of the saliva, a swab, and putting it under the microscope, or is there some like pregnancy test type of thing that changes from blue to pink?
So it's a test that where I work, where you have to insert a swab that goes into your nose to the back of your throat. It's not pleasant. Yeah. It may cause a very vigorous cough if you undergo it and not enjoy it. And then, in addition to the swabs being limited, at some places it's the reagent that's needed, the viral medium or the reagent in the lab. And it's been a long time since I was in microbiology lab, but basically, and I'm not an expert in it at all. But what we're trying to do is trying to be efficient and not waste reagent every time we get a sample for one patient. We have to batch them together. So we get X number of batches or X number of patients and run it per batch so you don't waste reagent. So that's like where we're at. We're still supply chain, like Dr. Ali said, isn't quite there yet. We can just get the test, run the test, get the result. If the batch just ran 2 seconds ago and your specimen shows up, you gotta wait till they fill up, until they get the next batch full, so you're not wasting reagent. At least that's where I'm at. Dr. Ali, I mean, I'm not sure if similar where you're at.
It's similar. Hopefully, we'll have the capability of running almost 1,000 tests at our institution. But like Dr. Hussain said, it's exactly that. We run clusters or batches of about 150 to 200 per batch.
Okay.
So, and once the batch starts, you can't individually stop for one test. So you have to wait for all of them to finish, and then you have the results for those 200 tests.
Oh, right. Okay.
And that can take another 6 or 8 hours.
Now, Dr. Hussain, you said we're kind of too late, in regards to some of the preventative measures that we could have taken place. And, I'm not going to get into blaming China. I know you guys didn't want to blame anyone, but I blame China because the facts are out there. People want to look at the articles that The Guardian put out regarding China knowing about this situation for months. The skeptic in me feels like they have the leg up on building things like ventilator systems and mass production of a global pandemic over every other country, which now the United States seems like it's scrambling to do with the inaction of the Stafford Act that allows President Trump to use industries that are related to like auto or technology industries to build these at a mass scale. But are we literally too late to flatten the curve? Is that whole notion of flattening the curve that everyone has heard about? I'm not going to go into explaining everything related to. Is that too late?
Well, it could be too late for certain regions of this country. It probably is already. I mean, I'm not an epidemiologist. I'm a pulmonologist, critical care doc. But what I've seen from New York, the data that I've seen come out, 12,000 plus cases, maybe 17,000 plus cases by last time I looked was last night. It's probably too late for that region to, again, the whole flatten the curve thing isn't about limiting the number of people who get infected. It's about spreading out when they get infected.
Yeah, so that the healthcare system isn't overburdened.
Right, and it's not just a burden the healthcare system. It's just like what the effect of that burden is. That burden is people die.
Yeah.
If the healthcare system is overrun, if you believe that doctors like Dr. Ali and myself can help people, well, it's a lot harder for us to deliver that help when we don't have the resources to do it. So if you believe that, healthcare saves lives and going to a hospital saves lives, then having it so that there's not enough ventilators around can then cause death.
Okay. Now, Prime Minister Imran Khan of Pakistan said that, we can't afford quarantine, lockdown, things like that. Our people are living hand to mouth right now. These type of measures just can't be put in place. We'll take the hit. We'll take it all at once, and it'll probably be at a very terrible human price. But what are your thoughts on that?
It's sad. I mean, I hadn't come across that yet. I hadn't come across that quote yet. But hearing that just hurts me in the chest.
Yeah.
Because it's going to be a very sad time.
Yeah. Well, you can say that, I guess, right now before they haven't yet fully experienced the spike or the highest point of that curve. I think when they see the effect of that hitting their hospitals and all their infrastructure, I think they may want to think through about what mistakes they made, but I think it'll be too late at that point, as Dr. Hussain already mentioned. Regarding the ventilator systems, what should we know about that? Are we going to be experiencing shortages in our hospital systems over here in the United States, to your knowledge?
Well, I haven't heard anything directly. I haven't gotten the phone with my pulmonary friends in New York or my pulmonary friends in Washington State. Yeah. But so I'm going to have the same information all of us here on popular media, which is it's either happening now or soon to happen in those places, to the point where my community, my critical care community, is getting ready for these tough decisions we may have to make in the upcoming, days or weeks. I mean, inshallah, it won't happen where I work or where I am. I'm hoping that the measures that we are taking allows this disease to spread out enough where I have enough ventilators for the patients that come, for the care at my hospital.
Yeah, exactly. So, anecdotally, again, we've already seen 2 mortalities or fatalities with the COVID-19 at our institution.
Okay.
As of today, and we are also working closely with the ethics department to see what patients might actually have to be excluded from getting a vent, which is very scary.
Yeah, it goes against everything we've been trained to do since the first day of medical school. It's just not part of what we're, raised to think about.
Yeah.
Is that kind of decision making. But
And those are the decisions that are being made in places like Italy and Spain right now because of their shortages. Those physicians are making life and death decisions on patients, deciding, who gets to live and who gets to die based on, factors like age, I guess. I guess who has a more potential to live life to their fullest is what I guess a physician has to make.
Right.
So you look at maybe a 30-year-old and you compare him to a 70-year-old, you're like, well, 70-year-old guy has lived his life already, and might be best to give it to the 30-year-old. Things like women and children come into play. You might want to give it to a woman before a man, or a child before an adult. So these, man, I can't even imagine being put in that kind of a position that physicians would, these type of life or death decisions that they're going to be making.
But like I said before, I mean, while I do think it's maybe some of the measures that we did were 1 or 2 weeks too late, there is, still hope to have our actions impact the outcome. As a person, you definitely do.
Yeah.
You yourself can choose not to, go out, see your friends, travel, go to a park where people are hanging out, have your kids visit your parents. Kind of activities need to stop, in my opinion.
Yeah.
Like a week ago, basically. So as a person, you have a lot of control about what happens to you. But as an ummah, we do too. As a community, we have that impact also, where we're able to, at least as a community, tell each other we're not going to do these things. So if the infection were to come to us, it'd come to us in a way which is slow and delayed, maybe past the spike. If other people in our country choose to pass it along and overburden our system, then it's unfortunate. But as your listeners can do is to educate themselves and educate their loved ones and their community. So not saying that less people will get sick, but when you get sick is going to matter a lot.
Well, so a lot of people are right now worried about Ramadan being canceled because of this. Are their fears founded? Like, can they not hope to see Ramadan, maybe even Hajj, in the next few months? What's your take on this? And I know this is more conjecture, and you guys don't want to, cause fear, but just pulling yourself apart from the situation and seeing the way it's playing out. Can these countries economically, forget about the religious obligation for a second. I know that's the highest thing, and it's the most important thing in a Muslim's life, but the Saudi government relies heavily, their economy relies heavily on the Hajj, and how are they going to stop that?
Well, right now we're looking at what? Today is March 22nd.
Yeah.
And we're looking at, inshallah, Ramadan starting April 23rd or so. Depends what calendar you look at. It's a month. Things are going to change. Inshallah, by then maybe the curve will flatten. But still going to be a virus which is amongst us. And I think some of the precautions that we're taking now will need to persist, even if we did the right thing early enough.
Yeah.
Meaning even a month from now, I can see myself telling my parents, you know what, kind of stay down in the down low. You don't have to be going out to every single. There might be not dawah at all. Seeing my kids, their grandkids may not be happening.
Yeah.
And that's going to be hard, but of course Ramadan will still occur. You'll still perform your fast. The food chain will still be there. I mean, it's not the grocery stores will still, inshallah, be full.
Well, a lot of if it was just me, part of me was like, if it wasn't my kids or family around me, I would just want to get infected and get it over with, just because it seems like the anticipation, the suspense surrounding, getting infected is just more stressful in itself, right? Like, am I, it would be one thing if you know that you're in a clear and you're kind of participating in this thing called herd immunity, where it's kind of theoretical right now, right? It's not like 100% fact that this herd immunity will play out the way models will project it to. But Dr. Akbar, can you explain what herd immunity is for the listeners?
Yeah, so I think I want to correct one thing first. Just because you're young, and as a pulmonologist, just because you're young doesn't mean that this virus doesn't have the ability to cause a cytokine storm and then a destruction of the alveoli, which are the basically the cells that help transport oxygen into the lungs or outside from the lungs into the blood vessels. So just because you're young and healthy doesn't mean that you will survive this infection. Okay, it's not a guarantee. Some people have underlying diseases that are never actually manifested until something else happens, and that underlying disease can be brought out by an infection like this.
Now, can bronchodilators or inhalers or other things help in that respect, or no?
We're using that for patients who are showing signs and symptoms. We're definitely using that as a treatment modality, but to start using them prematurely or to prevent this, no. Okay. I mean, that's again, we want to stress the fact, and it's a broken record, that staying away, trying to avoid being infected, okay, even if you're young and healthy, and not to become immune or not to think along those lines that, if I get it, I'm going to become immune, then I'm going to help everybody because I'm immune. It is still not the correct thinking. It might play out that way, but that's still not the right way to do things. And that's, at least from the data that we have right now, it's staying away, having proper hygiene, disassociating with everybody that you can. Even at work, if you have your little area, just stick to that little area. Do your thing and go home. Don't try to socialize in this time, because again, we're trying to prevent the burden on the hospital system and then preventing deaths. That's it. Preventing the burden on the hospital system is completely directly related to deaths, preventing deaths.
So, and regarding the herd immunity concept, how do people understand this? Because the herd immunity is directly related to this curve that we're talking about, this high, the maximum number of people who are infected will lead to a general sense of immunity in the population. Am I explaining this right?
So the way herd, again, I'm not an immunologist, and I've been learning from a lot of experts while we're doing this. Basically, this is a novel coronavirus, so it did not exist before 2019. Okay, this type of coronavirus did not exist in the world, and especially in the human population. And because it didn't exist at that time, we human beings weren't immune to it. Okay. So if you go to these Hopkins website or the Worldometer, they're telling you the number of people that have recovered. So basically, that just means the number of people that have tested, quote unquote, positive and haven't died. Okay, that's what it means. The recovery. That's what it means. Is yes, they were positive, and somehow they're still they're still living. So we can hopefully think we can kind of extrapolate that whoever's recovered is most likely immune. Okay, from the experts that I've talked to, they're saying that if you come down with this virus, you probably have lifelong immunity. If not lifelong immunity, at least for the next 4 to 5 years. Okay. And if enough of us in the population get this sort of 5-year or lifelong immunity, we will be one less person that's capable of passing this on because we're immune and we're not necessarily contagious.
Right.
Okay.
Does that make sense?
Yeah. So when we,
And sorry to interrupt, but then
Yeah.
the idea then is like for those who are not immune and who are in the quote unquote middle of the herd. So the herd travels how? Like the weakest and the smallest go in the middle, and the strongest are on the edges. So in the herd, the weakest, the oldest from our population, the oldest in the community, the youngest are then, or those who can't get, those who can't get immunized later on, who don't have, or on the wrong medicines that doesn't allow them to get an immunization shot later, for example. They never build immunity for other reasons because they have other immunosuppressive problems. Well, then they don't get hurt because the ones at the edges are the strongest ones who've built immunity, and they can protect the middle of the herd. And that's what we're trying to accomplish, but that's going to be doing it the way where we all get it at once is not the way to do it.
Yeah. So for example, like you have somebody in your family who has emphysema, or you have a young child with cystic fibrosis. Okay, and you are the primary caretaker of that child. If you and everybody else that's taking care of that child or that patient with emphysema is already immune, then because of that, those two individuals, the cystic fibrosis child and the adult with emphysema, is protected because you aren't capable of transmitting that disease to them.
Okay.
Because you are immune.
Okay.
So they necessarily don't need a vaccine. It's just we all act like a buffer around them because we're the only ones capable. We're the only ones that has the potential to actually interact with them.
Yeah.
And give them this disease if we were not immune.
Okay. Now, does this immunity protect against mutations of this? Like, for example, the flu vaccine, right? Mutates, every years? What is it?
Multiple times.
So, when we do develop some sort of immunity towards this, that doesn't necessarily mean we're fully protected. Or is that just the nature of this virus or viruses in general, that this is a reality that we always have to accept with viruses?
I think from the COVID-19 perspective, I believe that we are immune to that specific COVID-19.
Right.
Okay.
But then later on, the experts hopefully will be able to develop the proper vaccinations that cover variations that may occur later on. So that's why it's always a guessing game every year with the flu vaccine. I mean, did we nail the right components in our vaccine this year as a public health perspective to cover patients? That's why you always, some people always get the vaccine and still get the flu, and they say, well, that was a waste of time. But still, perhaps if enough people got protected from other strains, then the ones who couldn't take the vaccine got protected by the herd who could.
So while we're on the topic of vaccines, there's no, to my understanding, you can develop a vaccine as quickly as possible, but it takes about a year to test it. Is that correct?
That's my current understanding. It's going to be 12 or 18 months before we get a vaccine that we hope to get one that's reliable.
Well, why do we need to test it? Why can't we just throw it into the human population and deal with the consequences later?
Well, because it could cause death if you do it wrong. If you have too much of the virus strain that can infect a person, get them really ill. So the techniques they're using right now aren't even relying on the actual RNA of this virus to cause immunity in the subject. But I haven't seen anyone say they can get this vaccine done quick enough to avoid the surge of patients that may be upon us.
Right. I think, again, vaccine is a long-term play.
Yeah.
So for us right now, as the CDC and the WHO does not mention any vaccine that's actually even being, proposed to come out anytime soon, at least not in the next 30 days. Are there trials? Are there some pharmaceuticals and companies working on it? Yes. To my knowledge, they are working on it. I don't know how far they've gotten. There is a medication also. It's a antiviral that we have been using, invoking the compassionate use clause to get, again, by Gilead Sciences. And that still is in trials right now, experimental drug.
Now, there was a mention of some antibiotic that was being used. I can't remember off the top of my head. Do you guys?
Donald Trump likes a combination of hydroxychloroquine and azithromycin as a prophylactic, which hasn't been proven yet. And I think Dr. Fauci went on stage right after he did and said, look, this is not something which is going to be reliable enough to use as a cocktail that prevents infection.
Yeah. Well, how wouldn't an antibiotic even work in antivirals?
So a lot of antibiotics have immunomodulator properties. Okay, so even though they are an antibiotic and they're supposed to control or kill bacteria or certain mechanisms or certain machinery of bacteria, they can also help boost the immune system. Some of them can. There are some antibiotics known to man that can help modulate the immune system to prevent getting sick quite often, and while at the same time helping with the controlling the bacterial population. Now, what's interesting about that combination that you just mentioned is there are in vitro trials that have shown it to work. So in the lab, it's worked. Okay.
Okay.
And there are many health institutions, including University of Washington, in the state of Washington, in Kirkland, that looking at that population, they've actually made it part of their protocol. Okay. Our institution right now is actually looking into that too, and seeing if we need to make it part of our protocol. Okay. So we are behind. So, and it's unfortunate, but I do, quite often we just kind of criticize our bosses and managers and supervisors when they don't get things right. But I do want to take this time out to kind of applaud and commend, my personal institution, who actually, going back, I have a memo from them from January 21st that actually forewarned that this was going to happen, and they went into just basically planning mode. And we had 2 town hall meetings, one in February and one in March. And we rolled out these things that I'm part of now, these COVID-19 units. And we, as a whole group, a pulmonologist, infectious disease specialist, myself, who is a hospital medicine doc or an inpatient medicine doc, and a radiologist, we all round together on the sickest patients. That are either are definitely confirmed COVID patients or that have a high likelihood of being a COVID patient. So there are certain institutions that have really, really gone out of their way to take this very seriously. I think we just didn't have this coalescing power, because it was kind of like a systems issue, a systems failure, that we weren't able to do that for everybody. But now there's a lot of institutions making headway. Hopkins is doing it. University of Chicago is doing it. They were behind us actually a week ago. And I was in a meeting, and we had a consultant from a software consultant that mentioned that, hey, you guys were ahead of Hopkins and University of Chicago. Now they're able to, they're coming out with clinical pathways and protocols that's actually, they're kind of leaving you guys in the dust. So yes, there are a lot of institutions and organizations that are doing a very, very good job. I just think that the fact that we weren't prepared, we didn't know, and we continue to learn is a huge thing. So all these other things that are being mentioned, that this could help or that could help, and Dr. Fauci, of course, mentioning, let's not get ahead of ourselves, I think is true, because we do know what we are in control of, which is staying away,
right,
washing our hands,
right,
and practicing social distancing.
Well,
and it's cheap. It doesn't cost you anything.
How are you guys sharing all this information, though, that everyone's gathering? It seems like, you guys need your own, some sort of medium where you guys are sharing the latest developments, procedures, protocols,
right,
everything that can. It seems like there needs to be some kind of middleman who is a hub of sorts.
It is. I think every institution has developed their own, group of providers. The effective ones are the ones like where Dr. Ali works, where they've really centralized those doctors and providers who are going to care for these patients into a team of dedicated physicians and nurses and pharmacists who do it, so they all are on top of every patient in their institution and whatever's up to date. It's their job every day to find out what's out there. And where me and Dr. Ali go are places, like JAMA, Journal of American Medical Association, go to our respective societies for guidance, which, is hard to get, but at least we have a network of people we can interact with to get the information that we need. But there is a lot of homegrown, kind of homemade groups of providers and physicians who are just basically exchanging notes, like what I've come across. I speak Italian. I spoke with this doctor in Italy, and me and him talked. I'm watching YouTube videos from Dr. Grasselli in Italy as often as I can.
Yeah.
Head of Northern Italy, Milan, and what he's experiencing he speaks good enough English where I can understand it during my car ride to work. And that's what we're doing. And we're, it's been good to see the amount of collaboration, cooperation I've seen between doctors, friends of mine I haven't talked to in 15, 20 years.
Yeah.
We're all of a sudden exchanging notes. What have you seen? What are you doing? What have you heard? What do you believe? What's garbage news? What do you buy into? And that's why, I'm on my phone's off the hook, because those are the conversations I'm having. And again, trying to ignore the conversations which aren't worth having. It's almost as important to ignore what I need to ignore.
Right. Yeah. That kind of data can influence your decision making as well.
Mm-hmm.
I guess what I want to know is, in the next couple weeks, this is, I'm assuming, just the beginning. Whatever we're experiencing right now, your hospitals and both of your hospitals are just beginning to have a stream of patients come in.
Mm-hmm.
How bad are things going to get? Or is that just too early to say?
I don't think it's too early to say. I think, I think we can all pray that we've done enough early enough where people haven't transmitted to each other already. Everything we're seeing now is a consequence of actions that happened last weekend, what it comes down to.
Maybe 2-3 weeks ago.
Maybe 2 weeks ago. What we're seeing now in the hospitals and sick patients are a result of some contact they had. So maybe that this virus wasn't as prevalent as we fear it is back then, and people got their act together enough. But how bad can it be, and how bad am I afraid it is? I'm afraid we're following step by step what's happening right now in Italy. And that's just based on the numbers.
Yeah.
It's based on the numbers of how our curves look in terms of the logarithmic increase in cases.
Yeah.
Some people are finding solace that our death rate isn't as high as Italy, but if you look back on when Italy was at 20 some odd thousand cases, their deaths didn't cross 1,000 yet either. The deaths trail until it really ramps up. People have to be sick for a few days before they declare themselves as getting better enough, inshallah, to get better, or to get worse and pass away. So
Yeah.
I'm afraid it's going to get worse, a lot worse, and but I pray it doesn't.
Well, the United States has a very large senior citizen population as well. I know a lot of the people who said, Italy had such horrific numbers because of their large population of elderly people. And I think that same rule applies for the United States as well.
Yeah. Can you speak to that this kind of fake notion that Italy didn't have the capabilities that we have?
Where it hit Italy, in northern Italy, is their intellectual and their financial hub. It's the smartest doctors in the world. Dr. Grasselli is someone who I would listen to at a lecture. If I go to an international lecture and he's speaking, I would go highlight it in my little book and go talk. And now he's running this show there. And despite the team of doctors in that part of the world and their talent level, these doctors are the ones that I read about in the pulmonary world 20 years ago. they had to act together. They knew what to do. The problem was their country, and they'll admit it now, wasn't kind of blew off the need to shut down the restaurants, which thankfully we did, shut down the bars, which thankfully we did for multiple reasons, and shut down sporting events.
Yeah.
I mean, we did that thankfully, like, it seems like a year ago. It was like 10 days. I mean, it was like 11 days ago.
Well, I think a lot of the reasons why people didn't take it seriously enough, at least when I first saw it appearing, was the 2% mortality rate.
Yeah.
When you say, 2% mortality rate, who's going to get affected? The old people. There are people who already have underlying conditions, which is true. You know, most of the people, or a lot of the people who have succumbed to this illness had underlying illnesses as well. So is it strict 2%, or is there? What I'm saying is, let's just say we don't have any care for these people in place. Is that 2% going to be maybe 6%?
It could be higher if we don't have the resources to treat the patients. And I believe that doctors and hospitals make a difference. Then we are a lot more people would die if they don't have access to care, which is what happens when we have a spike. Is you don't have access to care. You don't have the access to me. You don't have access to Dr. Ali. You don't have access to what our machines that we have. If there's too many already, they're already there. And that's the problem. That's the problem Italy is having, and that's the problem that South Korea avoided because they flattened their curve. They had the illnesses occur, but they had the resources to take care of those patients. And then, thankfully, their death rate is low.
Sure. So, I mean, touching based on you have to think about it in two ways. There is the direct mortality from the virus itself, and then there's the indirect mortality from the lack of resources. Okay, so to kind of put in perspective, with the flu, right? This is 10-year data. These are averages. About 18 million flu cases a year in the United States. Okay, and about 400,000 get admitted to the hospital. Okay, and only a fraction of that, I would say about anywhere from 20 to 60,000 at the max, die from the flu. Okay, die from the flu directly. And now, but just because they had the flu, they don't put an undue burden on the hospital system. The numbers that I've seen in line with what's happened in Italy is that we may have up to 96 million people come down with this COVID. Okay.
That's an incredible number.
Yeah, incredible number.
We're talking about at least 1.7 to 2 million people dead at the end of this.
Right, exactly. So if there's about even if the mortality is similar to the flu, and let's just say even less than 1 million people die, 900,000, the fact that 900,000 dying from COVID-19 as opposed to 60,000 dying from the flu is a huge burden on the American healthcare system. And that 900,000 dying, and when we're exhausted and taking care of them, what's going to happen to all our other patients who have heart failure or having a stroke or having a heart attack, an MI, or who are coming in with other issues that we can't tackle because we're already drowning.
What would you suggest if you had some sort of authority in these matters? Anyone who's failed their step 1, step 2, put them on the front lines, hey, you didn't make it to med school or past med school for whatever reason.
We're already doing that.
Are we?
Well, my institution, we have chief residents actually, working in line with the residents and seeing patients where they normally would not have been. Okay, we are. I know from another source that they have recruited all the residents from all the other specialties such as surgery, neurology, and they've diverted them into medical to be on the wards, to be on the inpatient wards, to be on the front lines.
That's incredible.
And that's why, I mean, I have hope. I mean, it's scary, but I have hope, not just because they're being recruited to do it, but I have doctors who have nothing to do with the ICU calling. What can I do to help?
Yeah.
Like, what can I do to help you out? We see this coming just like you do.
Yeah.
What can I do? And everyone can do something. I mean, they have anesthesiologists can do something regarding getting these patients intubated, for example. That's what they do a lot. They have experience with the ventilators, the breathing machines, the certified registered nurse anesthetists, the CRNAs. They have skills that can be leveraged in these scenarios. So everyone has something they can do.
Yeah.
And we've got, and that's where it has to be some, creativity, some knowledge and every institution, every hospital is going to be a little bit different.
Yeah.
I mean, you got some rocket star surgeon who's an awesome surgeon, and guess what? He can repurpose him to do something else.
Yeah.
And that can be even like you said, the guys who don't know how to, who didn't get into residency, well, and if they have the courage, and I'm thankful that a lot of them do, to help just with triage, assessing. There's going to be fever clinics, I predict, where you're going to have you already see it, these tents in the parking lots of hospitals, just to initially assess where this patient should go. I mean, is it the real deal? Need to be tested. It's not a complicated, algorithm that needs to be figured out, but it has to be completed every single time reliably.
Yeah. I mean, it's way better than having some trooper from the National Guard, trying to make these type of calls, which would be completely, preposterous. But it seems like you mentioned Italy and how we're kind of following that model. But in your assessment, do you think in the next couple of weeks we'll really feel like, holy cow, we're really seeing the body count pile up?
I pray not, and I hope I'm wrong.
Yeah.
I hope I'm wrong too, but I feel that I know one thing for sure though, we're going to be extremely busy on the healthcare practitioners, physicians, doctors, everybody else, affiliated with the hospital system, urgent care, primary care offices, whatever. We're going to be very, very busy.
Yeah.
And I think, I just ask all of your listeners who Muslim, non-Muslim, we need prayers right now, for all of those.
Yeah, that's, I guess, to wrap things up, the next few minutes, what are your closing words of advice to our community, to the Muslim community specifically, and how they're handling, things going to the mosque and Ramadan being canceled? How would you tell them to go about things?
Well, I mean, it's like I'm by no means any kind of scholar or an expert in that, but what I can tell, you and your listeners is what I tell my family, which is we got to find the opportunity in this. And it's hard to say it, but I mean, you've seen the memes like quarantine equals quarantine, just read
quarantine,
quarantine, yes. I mean, there's for some people, I mean, it's a chance. You got to take advantage of the chances that you're presented with.
Yeah,
and if it means
you got to deal with what's right in front of you, you can't control what's what the possibilities are. The realm of the unknown is always a place where you can just completely get trapped in it and just going in cycles of, well, if this happens and that happens and that happens, then I'll lose my job, and then all these theoretical things can happen. That in itself can present all kinds of psychological dilemmas. I know people are calling. My mom was telling me her so and so friend was calling 911 because she thought she had COVID-19, and and the paramedics came and said, "Listen, sister, you're not presenting any symptoms of COVID-19. You can go to the hospital. We can take you there. You'll be facing a 7 to 8 hour limit, in a waiting line before anyone will even see you, or you could wait for some of those symptoms to present itself." Well, I mean, it's entirely, they kind of give her the option, but it kind of spelled out what the reality is at the hospitals right now. So
right, so I mean,
that psychological effect is another component that's layered onto all these millions of things that are completely interconnected. The people freaking out and going to the hospital itself is just crazy.
I would say, yeah. I mean, if you're sick and you know that you're sick and this is not how your body normally reacts, definitely you have to go to the hospital, okay?
Yeah.
And if you're having fevers and you're having a cough and the fevers are not getting better with Tylenol, then you have to go to the hospital because that could be COVID-19.
And if you're short of breath.
And you're short of breath, exactly.
Okay.
So that definitely, I think you have to go. But everybody else kind of just needs to take a chill pill and relax a little bit. And the other thing, you know, I mean, you mentioned about going to the mosques and stuff like that. I leave it up to the ulama to decide what is the correct course of action, the appropriate course of action. But from the medical perspective, I just wanted to say this, that the whole point of the lockdown by the mayor and the governor, at least in our state, the essence behind it is that you're trying to completely minimize any type of social interaction. Okay. And if people are actually going out to seek other people to do, prayers in congregation, even though the masajids are closed, I think that defeats the essence of what the lockdown and the self-isolation or self-quarantine was meant to employ. Okay.
Awesome.
So, I mean, I think that should be clear. I think, if people have that in the back of their mind, then I think they can make correct and appropriate decisions.
Yeah. I think that's something that is being repeated by a lot of the ulama, that, hey, you're not holier by you proving your ability to go to the mosque. Your willingness to sacrifice your life. You're not making yourself any more holy than anyone else.
Right.
You're actually proving to everyone how stupid you are by, in effect, carrying or possibly being the pathway of bringing a contagion to your family and your loved ones by doing this so-called pious act that you think you're doing. But again, a lot of people. I don't mean to upset you if you went to the mosque or anything. Just we're all learning as we go along, and maybe a week ago I probably would have as well, but.
Right.
Well, what I would recommend everyone...
And to be fair to the Muslims, I mean, I've heard that there's been other religious groups that are kind of doing similar things.
Right.
And I don't want to just, I think we expect more from the Muslims.
Well, because we're not as silly as some of the other faiths. We have a nice marriage of science. Our religion actually incorporates or is very accommodating to science. We don't, believe in some of the silly superstitions that come with other faiths. I'm not going to call out any other specifically, but let's just say we can perfectly believe in prayer and science together.
Yes, for sure.
Anything else, guys? Did I miss anything that you guys? I know I sometimes Dr. Akbar, we grew up together. You remember the show Quantum Leap?
Yeah.
The guy has to go through. Yes, he's sent back into time or whatever, and he plays these different roles. And right now is my science role. A week or so ago, it's like a philosophy role. So this is how I kind of view my life. I have to kind of quickly become a student of various practices and then be able to speak on it. So if I missed anything, please forgive me, and if hopefully it doesn't come to any loss of life related to my shortcomings. But yeah, if you guys have any comments or thoughts, make sure you put in the YouTube video below or the comment section in the YouTube video, and hopefully someone educated will look at it and respond accordingly. All right, guys. Thank you so much, Dr. Ali, Dr. Hussain.
Thanks for having us.
I appreciate you. You guys have a very busy schedule, and you made a huge sacrifice. Instead of being with your families, you came and helped the Muslim community understand a little bit more about this and hopefully put things into perspective.
Just one last comment I have to say, because you brought with the Quantum Leap story, was that I think we are going to look back in the next, look later in our lives, inshallah, we'll all have long lives, but we're going to look back in 2020 and really know what we're made of and how we did it. Like how we, inshallah, will do the right thing, help each other out, help our parents out, help our family out, and we're going to find out the good of people in the next few weeks.
So far, alhamdulillah, I have to say, I've been surprised. I thought self-imposed quarantine people would never accept that. I mean, it's still early in the game. Hopefully 2-3 weeks later they're still, as passionate about it as because sometimes when you don't see the illness in front of you, they'll be like, everything's all right. Well, what these medical professionals, what does Dr. Ali and Dr. Hussain know about this?
That means we did it right. That means we did it right.
Yeah. So hopefully 2-3 weeks we'll know a little bit better about the situation. Hopefully maybe you guys can come back and give us a briefing on how or what things went right, what things went wrong, what things we could probably hope to improve on. Jazakallah khair, everyone. Thank you so much, brothers. Anything else I missed? Or that's it? All right.
Beautiful.
We'll see y'all later. Assalamu alaikum.
Wa alaikum assalam.
Assalam.